I'm going to tell you about respiratory failure. It's a mechanistic approach to respiratory failure, so you don't have to remember it. You will see everything in front of you developing how people get respiratory failure. Now, how many types of respiratory failure do you know? Two. Wrong. It's four. We'll go through the types of respiratory failure, the mechanistic approach, management, and then we'll not go on mechanical ventilation. So we get four. There's a perioperative, which is there's been going on for a few years, and there is also shock-related respiratory failure. Okay? And we'll go through these each. The mechanism of respiratory failure, the hypoxic respiratory failure, the major cause, one of the major causes is alveolar hypoventilation. The second, I call it ventilation abnormality. In the books, they call it ventilation perfusion mismatch. Okay? I think the terminology is a bit difficult to understand. And then the other cause of respiratory failure is the perfusion defect, shunt, what we call shunt. Okay? And then the other causes, rare causes, reduced FiO2 and the reduced mixed venous. That's the whole thing. Now, alveolar VQ mismatch mainly talks on ventilation abnormality. It's the top part of the limb, airway and alveoli and basement membrane. When they talk VQ mismatch, it's usually ventilation abnormality. And what causes this is airway obstruction, alveolar problem, such as interstitial lung disease with fibrosis. And these are ventilation abnormalities. At the top is asthma COPD, and at the bottom is fibrosis. Then the alveolar hypoventilation, the whole system falls down, and usually when there is CNS drive is reduced, neuromuscular coupling is reduced, and when there is increased dead space ventilation, that's your PE. So these are the main ones for alveolar hypoventilation. The shunt is when the blood comes from the mixed venous. This is mixed venous oxygen. It comes 70, normally it becomes 99. 100%. When there's shunt, it bypasses this alveolus and it comes 70, comes out as 70. Okay? Now why do you shunt? Shunt is maybe 10% of all hypoxic patients. Ventilation is about 90%. So most of the people that you see with hypoxia is COPD and asthma and whatever. It's a ventilation abnormality. Now, the mixed venous bypass the alveolus. You can bypass the alveolus if there are three things in the alveolus: fluid, blood, and pus. Okay? Pus, example of pus is what? Give me an example of pus. Pneumonia. Fluid?
Pleural effusion.
Pleural effusion. Anything else better than that? Yes, left ventricular failure. Good. Blood, alveolar hemorrhage, anticoagulants, vasculitis, things like that. Okay? So these are three things that cause. So you can see now how people get hypoxia. You have to go through these. This is the oxygen dissociation curve, where you can see that patients do tolerate hypoxia pretty well in real life. And when the PO2, this is 50 millimeter, about 7 millimoles. And once you reach saturation of about 90, it becomes very steep, and your your oxygen goes down very quickly once you reach 90. So we like to have patients between 88 and 90 so that he can sit at this curve, at there. He can sit there. Okay? That's what we like to do in those patients. What are symptoms of hypoxemia? What does the patient present to you in hypoxemia? How do they present?
Agitation.
Agitation? Yes?
Dyspnea.
Dyspnea? Okay. You think of the diseases and then you can think of it. And then signs.
Wheeze.
Wheeze, okay. Okay, it's all over the place, but we'll go through it systematically. So people become cyanosis with their hypoxic. They do have clubbing, okay. Those with congenital heart disease, they get clubbing. And look for mucous membrane mainly. Respiratory system, shortness of breath, as we said, tachypnea. Pulmonary hypertension, cor pulmonale, they are blue, usually. Cardiovascular system, they can get arrhythmia, bradyarrhythmias, hypotension, angina can be precipitated with hypoxia. Hematologically, as a result of hypoxia, the bone marrow reacts and it causes polycythemia. What causes polycythemia? What hormone causes polycythemia, increased red cells?
EPO? Erythropoietin?
Yes, very good, erythropoietin. And then you come to the central nervous system. The whole brain doesn't work. From concentration, inattention, clouding consciousness, memory, confusion, and convulsion. And then it does have some effect on the kidney, which is probably not significant. Treatment, what do you do if someone is hypoxic in front of you? So go through the diseases that I have put forward, the ventilation part. The main treatment is oxygen. If you're hypoxic, you get oxygen, okay? And the second thing you do, you treat the cause, okay? If it is infection, antibiotics. If it is alveolar hemorrhage, you treat it with whatever the cause of the hemorrhage, like anticoagulants or whatever. Left ventricle failure, you treat that. So you do these, and then at the end, when you don't have much response, you do non-invasive ventilation. It doesn't work very well in hypoxic patients. It's better for type 2 respiratory failure. So most of these patients with pneumonia are sick. You put them on an IV, they don't tolerate it well, and they'll end up with mechanical ventilation. So this is the progress of patients. What do you give for left ventricular failure? If someone comes breathless in the middle of the night, what do you do? What are the drugs that you give them? Oxygen? What else?
Furosemide.
Furosemide?
GTN.
GTN? Very good. Why do you give furosemide?
That's it.
Who said furosemide? Why do you give furosemide? Where does furosemide work?
Dilate the renal loop.
Dilate the renal loop.
Yeah.
I don't think there's anything that dilates the renal loop.
Trying to put it to the right place, the preload to the right place on the Starling curve so the heart can pump better.
I didn't understand what you said.
So you give the loop diuretic so
Yeah.
to reduce the preload on the heart so the heart can become the right place on the Starling curve. And then does that allow the better circulation?
Okay, but it's a diuretic, isn't it? And it works on the loop of Henle, all right? So you reduce the blood volume, okay, with diuresis. But it has another important action. Vasodilatation. Okay, it's important, vasodilatation. Morphine as well, you give. You forgot about morphine. That's another one. You reduce all the baroreceptors and stretch receptors in the lungs and makes the patient feel better. In fact, morphine is probably the first drug I would give. Okay? So that's how you treat it. So we finish with type 1 respiratory failure.